So hello, this is S.Deiter. This is my checkout video for the final for Dr. White in my advanced assessment class. I have here my simulated patient, my wife Natasha Kelly Deiter, who has consented to, or I should say, do you consent to be filmed for this fake health assessment?
Yes.
Okay, all right, so she's consented. We'll send the written form in as well, and we'll get started. So just please note that some of the activities will be simulated, as I have not yet acquired a otoscope or ophthalmoscope or other issues, but I will talk through those so that you know that I'm aware of what they're used for and how to use them. And once my practice gets off the ground a little bit, I will be able to afford the high-end equipment. So I'll just explain things as I go, and we'll get started. So first, the patient has come into the room and is sitting on the stool, and that allows you to begin the general survey. Just the very fact of her walking in, having a brief conversation, answering my questions appropriately, gives me insight into the patient's mentation, their general gait, any sort of musculoskeletal issues that would be red flags at the start. In this case, the patient appears comfortable, clean, well put together, her answers are appropriate, and we've uncovered no red flags in the beginning of our survey. With your health assessment, you want to be concise and have a systematic approach. So in this case, we're going to start, I've chosen to do a head-to-toe assessment, and I plan on intermingling in the different assessments, both for brevity, clarity, and to make sure that nothing gets missed. So for example, when I'm reviewing the head, I will check skin, cranial nerves, musculoskeletal function, and any other stuff that I have to do as I move along, as opposed to doing nerves and then back through and cardiovascular and so on and so forth. So with that in mind, I'm going to begin by inspecting and palpating the patient's head. So as you can see, everything is intact. The hair is well groomed. There are no obvious bumps or cliffs in the skull that could indicate fractures. As you see, the patient is not reacting with any pain or distress to indicate that there are any issues underneath the scalp. Skin looks moist and free of any obvious blemishes or rash or any other issue. Next, we will palpate the temporal artery. And again, this will be part of the cardiovascular assessment, but we mixed it in here because there's no point in just going back. So we have a nice even pulse on both sides. The pulse is regular. The patient's heart rate is in the 80s and regular, and a good, nice +2 pulse on both sides of the temporal artery. Next, we'll assess the TMJ, the temporomandibular joint. And so what we'll do is put our hands on the TMJ and ask the patient to open their mouth and move your jaw around in this fashion. Okay. And go ahead and close your mouth and open it again. All right. And so what you have here is there was no popping, there was no clicking, which could indicate damage to the TMJ. Typically that damage is unilateral and would need to be followed up to prevent further dislodgement or damage to the joint. Next, we're going to examine the eyes. So we look at the patient's eyes, we inspect, everything is clear, the sclera is nice and white, there is no frank redness or discharge. We will look at the under eyelids, everything is nice and red, there's no discharge, there's no frank redness. The tear ducts are visible but not overly so, they appear intact. If you look up and look down, so the upper eyelids function consensually. They're both moving at the same time. There's no frank distress noted in her eyes, no redness, no swelling, no discharge. If you examine the lacrimal apparatus, which is the lacrimal ducts, sometimes if there's an issue, when you press on the lacrimal apparatus, you can have discharge come out. In this case, there's not. Is this painful as I'm pressing? No. No. So there's no pain reported when assessing the lacrimal apparatus. And the conjunctiva is intact and moist and pink. So the external eye exam is normal. Her eyes are blue. Her pupils are 4 and generally reactive to light, though we will assess that further going forward. With that in mind, we are going to use this pen to assess the cardinal fields of gaze. And this will allow us to assess whether cranial nerves 3, 4, and 6 are intact as the patient moves through the cardinal fields of gaze. So what I want you to do is focus on the pen, and without moving your head, follow the pen around, okay?
Okay.
Okay, so the cardinal fields of gaze are intact there, and there was no extraocular movement, such as strabismus or any other sort of shaking of the eyes as they track the pen around, indicating to me the cranial nerves 3, 4, and 6 are intact. Now we will assess the patient's visual field. So I want you to tell me when you can stop seeing this. Keep your head forward just like it is now, right?
Mm-hmm.
And tell me when you can stop seeing.
Now.
Okay. So the patient has a very wide peripheral visual field, which is normal, and everything is intact. And was it equal on both sides?
I could see this one a little bit longer.
Okay, so she reports that she can see the left side a little bit longer than the right. So what we will do is assess each one individually to see where the visual field ends. Looking forward, please.
Sorry.
Yep.
Can't see it anymore.
Okay. So we're going to call that 8 degrees off baseline from the edge of her face.
Can't see it anymore.
Okay. And on that side, it goes all the way down to baseline. So it seems like the left eye, in this case, has a wider visual field. Now, when you have an issue like this, you want to assess further. Is it just that her peripheral vision is a little weaker on this side? Or does she have something like a field cut that would be indicative of a stroke? And the way that I will do that is try to assess her visual field from the side. Can you see my fingers over here?
Yes.
Okay. And see my fingers over here?
Yes.
Okay. So there's no field cut or area of darkness that could be indicative of retinal damage or stroke, even in some patients who would lose part of their visual field. So it just seems in this case that her peripheral vision on one side is a little stronger than the other, which is not uncommon. Very often patients will have a dominant eye and a weaker eye. And that's benign. It's just something to note, but it is benign. Next up, we will use the fundoscope, which of course we are going to simulate. And the purpose of the fundoscope is to combine both magnification and light to allow us to see the inner surfaces of the eye and to assess the retinal disc, the optic disc, the cup margins, whether there's any issues with vessels. Sometimes the small vessels in the eye can become crossed, causing lack of blood flow and damage. With conditions like glaucoma, the optic disc or the margins of the optic disc can be hazy as opposed to a well pronounced border. And you should also be able to elicit a red light reflex, which is simply produced by turning the light on the fundoscope on and having the patient look straight ahead in a darkened room, and you would come from the side with the light heading towards the center, and at about this point in my experience you would see the red light reflex where the reflex of the right would cause the pupil, the back of the retina, to show up red, and that's a normal finding. That's what you're looking to elicit. It allows us to determine if the structures of the inner eye are grossly intact. So we would do that on both sides, again assessing for red light reflex and noting the structures of the eye, looking for any damage, and seeing if anything would need to be followed up with an optometrist to further evaluate and give us an indication as to how patient is managing chronic disease states such as diabetes, which can lead to glaucoma, hypertension, and other issues that can affect vision. In this case, we will move on past the simulated fundoscope and move to the nose. So here we will use the otoscope or ophthalmoscope to first we'll visualize the structures of the nose. Everything seems to be grossly intact. There's no pain on palpation. The nose is midline. There's no frank damage, no piercings, which is a common thing now. And then we would use the scope to look inside the nose at the structures. Okay, so you're going to examine the nares, you're looking at the mucous membranes, you're looking at the turbinates, you're looking for the septum. Is it intact? Could it be deviated? Is there any bleeding? Is it dry? The mucous membranes in the nose should be moist and pink. You could also see, frankly, in children, you could see foreign objects if they had placed them in there. And you can get a good indication of the patient's general sort of health of their mucous membranes by looking in their nose, and it should be equal bilaterally generally. So in this case, we would do the right nair and then the left nair, looking in for all the things I just described. And then, although it's not commonly done, you can assess cranial nerve 1 by sense of smell. So I have an object which I'm not going to show to the patient, and I'm going to have her smell it, and with her eyes closed, and see if she can identify it. So go ahead and close your eyes. Smell it. Can you tell me what it is?
Garlic.
Okay, so it's garlic. Because this patient also happens to be my wife, I didn't cut down the piece of garlic because that could be a problem. But naturally, a negative stimulus in terms of smell is what you're going to want to do to, or not even necessarily a negative stimulus, but something that's going to, not a light smell, something that's going to be easy for them to recognize and commonly known, so that you can assess whether or not that cranial nerve 1 is intact. In this case, she got it correct, and cranial nerve 1 is intact. Next, we are going to examine the frontal and maxillary sinuses, 2 of the larger sinuses in the face. So it just happens by palpating around. And if a person is having a sinus infection or any kind of upper respiratory infection, this can be painful, so you want to start with gentle palpation and move through to deeper palpation. Is there any pain as I'm going around?
No.
No. Okay. So the frontal and maxillary sinuses, as well as the lacrimal apparatus, is all intact and not painful, and frankly benign, free of abnormal assessment findings at this point. Next, we will examine the mouth and the lips. So can you stick your lips out like this? Okay. Can you smile? Okay. Can you squeeze your eyes tight, real shut? Okay. And lift up your eyebrows? Okay. All right. Now open your mouth. Okay. All right. So the lips are pink and moist. Everything moved in unison, allowing me to assess the cranial nerves of the face as we were doing this assessment. There's no dryness or redness around the corners of the mouth. If you begin to look inside the mouth, open your mouth, please. You can see the hard and soft palate. The tongue is moist and midline, as is the uvula. Say ah.
Ah.
All right, the uvula is midline and rises equally. In a situation where there's damage to the cranial nerve, or sometimes, as in the case with tumors, you can have a deviation of the uvula to one side or the other, depending on the particular malady the patient has. But in this case, the uvula rises and falls equally. Additionally, stick your tongue out, please. Stick your tongue down, please, like out of the way. Okay. All right. So additionally, the tonsillar pillars are +2, normally positioned, not red. There's no redness or inflammation or any other discoloration in the mouth. And then now I'll just briefly look at the patient's gums and dentition to complete the mouth assessment. Open your mouth. Have you had your wisdom teeth removed?
Yes.
Okay. The patient has all of her teeth, all of her adult teeth, which appear clean and intact, with the exception of her wisdom teeth. And her gums are moist, they're not bleeding, and there's no negative findings in the mouth. Now that we're in here, we will assess her gag reflex. So we'll just have the patient stick her tongue out and gag. Okay, gag reflex is intact, and we So cranial nerve 12, as well as 9 and 10. Cranial 12 controlling the tongue, and 9 and 10 controlling the gag reflex. This is especially important on patients who are post-stroke or the elderly to observe for signs and symptoms of aspiration. Moving on, we're going to look at the ears. So first, what you would do is, as always, inspect. So we're just inspecting the structure of both ears. They are equal in terms of how they are spaced. They are similarly shaped, free of pain, free of redness. These ears appear to be pierced. There is no discharge on the outside of the ear. So structurally they're intact and they're midline. We will next try to begin to assess hearing before more thoroughly examining the structures of the inner ear. So what I'm going to do is whisper 3 words to you from varying distances and see if you can hear them.
Okay.
Okay.
Cat. Hat.
Rat.
Rat. Dance. Pants. Ants.
Okay. The whisper test is intact. The patient was laughing, but the laughter is appropriate. Inappropriate laughter during an exam can be indicative of many different things, some of which could include psychiatric disorders or other issues that you would need to look at more closely. But again, this is a hint to hermentation because the words I chose were goofy and she laughed. That's an appropriate response. It also indicates that she could hear at all 3 stages, which is appropriate for a, how old are you?
37.
37-year-old woman. You wouldn't expect necessarily any hearing issues or difficulties. So next we're going to use the Rhine and Weber tests. So again, we don't have the otoscope, tuning fork, but we will simulate it and I'll explain what we're doing. So this is a test to determine air conduction and bone conduction. So typically air conduction should be greater than bone conduction, meaning the sound that travels through the air should last longer or be heard longer than sound that travels through the bone. And if it doesn't, it's indicative of a number of hearing problems that we would address if they arose in the patient.